Chapter 31 talks about periodontics. It starts on page 723 of your dental assisting textbooks. And some of the things that we'll be discussing is describing the scope of periodontics. We'll talk about the members of the periodontal team and their roles. We'll explain the diagnostic procedures involved in the patient's first visit. We'll identify and describe periodontal instruments and their uses. We'll talk about the use and benefits of lasers in dentistry. We'll also describe surgical and non-surgical procedures and the dental assistant's role in each procedure. And we'll explain the purposes of periodontal dressings and the different types of periodontal dressings available. And we'll also describe the periodontal maintenance procedures and the patient's role relating to each. So periodontics is a specialty that deals with the diseases of the tissue around the root of the tooth. Perio means around and dontia means teeth. 3 out of 4 adults will experience some form of periodontal problems in their lifetime. And the objective of the periodontist is to identify the symptoms and probable causes of the disease and diagnose and treat the disease as needed. So the periodontist will screen the patient and coordinate with the dentist. Some dental assistants' responsibilities include room preparation and chairside assistance. The dental hygienist is responsible for cleanings and deep cleanings, as well as something called scaling and root planing. They are also the person or the people who do the initial periodontal examination. And the business office staff handles insurance claims. They deal with scheduling the patients and connecting them to the correct specialist. The dental assistant's role can also include periodontal dressing placement and removal, sutures removal, coronal polishing. They can take radiographs and impressions. They can apply fluoride treatments and provide patient education. So the dental assistant's function can vary because of state regulations, experience, etc. And as you can see, the dental assistant's role can become much more than just room preparation and chairside assisting. Symptoms of periodontal disease can vary, and they can be experienced along with gum disease, many of which can be very uncomfortable or embarrassing. And they include bleeding or inflamed gums, periodontal pockets that are larger than 3 millimeters, malocclusion, which is an incorrect bite caused by bone loss and moving teeth. Halitosis is just really bad breath that comes from the odors that comes from the bacteria that causes periodontal disease. Tissue recession can occur, as well as abnormal contour of the tissues. And also pain, tenderness, and discoloration can be felt by the patient. Some causes of periodontal disease include local irritants or bacterial plaque, mineralized, and they appear as yellow or brown deposits on teeth. Hard deposits is called calculus or tartar. Poor oral hygiene results in the buildup of tartar and plaque. Improper nutrition leads to bad health overall, and tissues can carry the disease. Malocclusion is improper tooth alignment or improper bite. When this is the case, food and debris is not easily removed and can actually exacerbate or make the problem worse. Stress can lead to grinding of the teeth. Systemic factors include anything from hormonal imbalance to other hereditary predispositions, such as certain diseases and medications that need to be taken because of those diseases. Gingivitis is where the gingival tissue becomes inflamed and is common among all ages. Causes may include poor fitting appliances, plaque buildup, and other non-plaque induced reasons such as diseases or drug therapy. Periodontitis Periodontitis exists when the fibers recede and supporting bone becomes inflamed and destroyed. Chronic periodontitis is a progressive disease process with the patient experiencing loss of tissue attachment and bone. Necrotizing ulcerative gingivitis, also known as NUG, occurs most frequently in young adults. Causes include stress, smoking, poor diet, poor oral hygiene. Um, can frequently occur in it can frequently occur in college students around the time of around the time of final examinations due to stress. And these patients can sometimes um, experience a metallic taste in their mouth, bad breath. There is usually pain associated because of the gum tissue is inflamed, and tissue hemorrhage or bleeding is usually a, a telltale sign of periodontal disease. These are just some pictures of some severe cases or advanced gingival inflammation and unhealthy gingival tissues or lingual calculus. So on the left, we see an example of what unhealthy tissue looks like. We can see that the borders of the gingival or the gum tissue is rolled and inflamed or swollen. We can also see that there is a lot of redness and puffiness in the gum tissue. On the right, we see what is called sublingual calculus. This is calculus or tartar that commonly builds up on the lingual surfaces of the lower anterior teeth. And that's usually what it looks like when we see stuff like that. It can usually be assumed that that calculus goes down below the gum level. So what is a condition or of recession of periodontal fibers and resulting inflammation and destruction of bone? We talked about this just a minute ago. This is periodontitis, or the whole reason for this discussion in periodontics. So there are some periodontal diagnostic procedures that need to be done. With periodiagnostic procedures, you want to refer to the patient's medical history. And in that medical history, it should include the patient's chief complaint or why they came in, their complete medical history, which includes any other diseases or medications that they're taking, oral history, as well as their oral habits should also be noted. So these questions can include examples such as, why did you come to the office? What areas, if any, are causing you discomfort? Do you have pain in your ears or mouth? Do you have any sores or inflamed areas? Are you taking any medications or treatments? Do you have any adverse responses or allergies? Are you pregnant? Do you have any diseases? And also provide information about your oral history and habits, such as extractions, cavities, smoking or alcohol abuse, and brushing and flossing techniques or habits. So with every dental examination, including a periodontal examination, it should always start with an extraoral examination. This includes observation of the skin and lips around the mouth, and palpation of the lymph nodes, such as what's doing here, and the TMJ as well. The TMJ is where your jaw kind of meets right in front of your ears here. These are all areas that should be addressed during an extraoral examination. Intraoral examination combines viewing and palpating the tissues in the oral cavity, looking to find any abnormalities in color, size, texture, or consistency of all the tissues. Thorough examination consists of evaluating all of the patient's oral hygiene areas and charting them. Plaque amount must be noted. Periodontal probing measures the depth of the pockets where the normal sulcus should be 3 millimeters deep or less. When it's deeper, 6 sites are probed and recorded. around every single tooth. Primary or basic instruments are used for this purpose. Tooth mobility measures by pushing the tooth. So if the tooth doesn't move around at all, it's normal. Um, and if it moves more than 3 millimeters in every direction, it's considered severe. So moderate would be somewhere in between that. Furcation involvement measures the destruction of interradicular bone. Now, furcation, if you can remember, it talks about or refers to the area on the tooth where the roots split. And when we start to see furcation involvement, or when we start to see that furcation in the mouth, which should be buried under bones and under bone and gums, when we start to see it in the mouth, that means there is furcation involvement where the periodontist has to actually go underneath that area of furcation and clean that area out. The appearance of the gingiva should also be evaluated in terms of color, size, shape, texture, position, consistency, bleeding, and amount of pus. Recession is the loss of tissue exposing the underlying cementin or dentin. Gingival cleft is a fissure or elongated opening that extends toward the root of the tooth. The margin of the gingival tissue forms a V when it should instead of a smooth, rounded border, which exposes the cementum covering the root. Occlusion is described and checked with articulating paper or wax to identify excessive biting and chewing. Periodontal screening and recording indicates the need for partial or full periodontal evaluation. Early detection should come with timely screening, and the procedure involves dividing the mouth into sexton sections, where there are 3 sections of the maxilla and 3 of the mandible. So, in other words, 3 on the upper jaw and 3 on the lower jaw, and probing each sexton or section on each tooth. The probe is used to assess the relationship of the gingival margin and the color band on the probe. The patient should also be educated during every step of the way to ensure their comfort and to make sure that they are on the same page as you. So this is just some radiographic interpretation of periodontal disease. Bone loss is usually shown on radiographs, and they are usually shown on a bite wing or sometimes a periapical. Here on the left, these are both bite wing x-rays, by the way. On the left side, we see, if you look very closely, we can see like a huge, it's like a crack that goes, or this hollow open space that goes way kind of up above this area. This is known as vertical bone loss or vertical defect. And you can see on this right surface, on this right hand picture here, we do have some bone loss, but it doesn't go vertically, it's just horizontal. So this is kind of the easier or the less severe cases when you have horizontal bone loss. That's just because the bone is, yes, it's gone away quite a bit. That bone should have been somewhere around this area here or close to the cementum or the CEJ, which is around this area here. And it's dropped down quite a bit here in all areas. But it's not as bad as having a vertical defect where there is lots of bacteria that can hide in this crack of bone here. There are chemotherapeutic agents which aid patients who did not respond well to the removal of dental deposits or the aggressive form of periodontitis. And these include antibiotics such as penicillin, tetracycline, erythromycin, or clindamycin. Also anti-inflammatory substances such as ibuprofen or acetylsalicylic acid, which is just aspirin. So at the consultation appointment, charts, photographs, and models should all be used to help your patient understand his or her situation. Once all the questions are answered and the treatment plan is understood, appointments and financial arrangements are completed. Periodontal instruments should be sharpened to make sure that they are effective um, and maintain efficiency. Stones and sandpaper can be used to manually sharpen tools, and there are many techniques that can be used. Although a machine to sharpen tools may be expensive, they are very effective, precise, and consistent. There are a variety of periodontal probes with colors and other indicators um, that should be calibrated before use, or especially when the instruments are new. Periodontal explorers can detect and locate calculus, tooth irregularities, faulty margins on restorations, and furcation involvement. Curettes are used to remove subgingival calculus, smooth the root surface, and remove soft tissue lining of the periodontal pocket. The cutting edge is usually the working end on curettes. Scalers are sharp hand instruments that are used to remove hard deposits. A variety of shapes and angles exist to access all surfaces of the teeth. And some of these instruments include sickles, jaquette scalers, chisels, and periodontal hoes. Periodontal files are used in a pulling motion to remove calculus and for root planing. They are also used to remove overhanging margins of dental restorations. The ultrasonic scaling unit is used to remove hard deposits, stains, and debris during scaling, curettage, and root planing procedures. They're used as an adjunct or an extra to manual scaling procedures. But what I found that is most hygienists and periodontists um, use this instrument as their workhorse, or the instrument that they use most for the heavy lifting of the dental cleaning and deep cleaning. The air polisher system is used after scaling and root planing, and also can be used prior to sealant placement and bonding procedures. The disadvantage of this system includes significant aerosol sprays full of sand, which is contraindicated for patients with respiratory illnesses. It can also demineralize the enamel and cause mild stinging from the reflective spray of sand. Other periodontal instruments include periodontal knives, interdental knives, peritomes. Peritomes are used to sever the periodontal ligaments prior to atraumatic extractions and to prepare the tissue for dental implants. Surgical scalpels are also used, as well as electrosurgery instruments. Other instruments include pocket marking pliers, periosteal elevators, periodontal scissors, rongeurs, which look like little pliers that are used to clip um, extra tags of bone, and forceps. So these are just a couple of instrumentation techniques. When we talk about supragingival curettage or supragingival scaling, we're talking about above the gum tissue. Supra means above and sub means below. So here you can see the scaler is getting to just all the debris that's above the gum tissue. Whereas on the sublingual picture here, the instrument is getting way below the gum tissue. And this particular instrument looks like it's only able to go so far until other instruments will be needed to get way down here. Lasers are instruments that are being used more and more in dentistry today. and they have a lot of different uses in dentistry, especially in periodontics. They offer a precise beam of concentrated light energy that's its efficiency is based upon the absorption rate of wavelengths, and those can be adjusted according to what that laser is being used for. The dentist must attend training and be qualified to use a laser in the office. So not just all dentists can use lasers. Many different wavelengths are used, and a special type of protective eyewear also must be worn in any operatory where lasers are used, and that should be used by all the clinicians in the room as well as the patient. So lasers have a variety of uses in the dental office. They can be used on both hard and soft tissue. Their uses include debridement and curettage, gingivectomy, where certain portions of the gum tissue is removed. Gingivoplasty means certain portions of the gum tissue is reshaped. Frenemectomy is a complete removal of frenums, usually why people are tongue-tied. They can be used to remove tumors and lesions. They can expose implants that had been placed, and they can also be used to remove aphthous ulcers. And that's not all. They can also be used to fuse tissue for tissue fusion, or elimination of granulation tissue, which is just dead gum tissue. They can be used for biopsy reasons, for crown lengthening, and we'll talk more about crown lengthening when we get into um, the crown procedure. And lasers also control bleeding as well as osseous procedures. The benefits of lasers is they provide bloodless operating field. This is because as they are working, or if they're used to cut tissue, for example, they're also the heat from the laser also cauterizes the tissue completely, so that the tissues don't bleed. This is really nice because it improves the vision to the operator, so that they are only making the most precise or the most necessary cuts. Another nice thing is that there is minimal to no anesthesia required. There is minimal swelling and discomfort to the patient, and improved coagulation. So if there is any gum bleeding afterwards, it usually stops or coagulates right away. Other benefits include minimal healing time, reduction of tissue damage and infection. They are very accurate because that beam can be honed into a precise location, and they are less time to use than other methods or other traditional methods of dentistry. So for what reasons are periotomes used? If you can remember a little earlier in our discussion, they are used to sever the periodontal ligament prior to atraumatic extractions and to prepare tissues for dental implants. Non-surgical procedures include occlusal adjustments, which are made to the occlusal surfaces or the biting surfaces of the teeth, so high spots are reduced. This allows all of the teeth to make full contact. Scaling and polishing is commonly called prophylaxis. It removes plaque, calculus, and stains and creates a smooth surface that is more difficult for plaque to adhere to. And here we just see an example of instrument placement for scaling. And that's just one example of the different places where they usually are placed to scale off a lot of this debris that you see on the tooth here. Other non-surgical procedures include root planing. Root planing smooths the outer layer of the cementum, making surfaces harder for plaque and calculus to attach to. Gingival curettage is soft tissue curettage scraping of the gingival walls of the pockets. It removes inflamed tissue and debris and is usually performed after scaling and root planing. Anytime a patient goes in for a procedure, certain instructions should be given preoperatively. Number one, you want to confirm that the patient understands the procedure. If they don't, or they're giving clues that they may not completely understand, re-explain the procedure and answer any questions that they may have after. Also confirm that the patient has prepared as instructed. And you want to give the patient's instructions if the patient is to receive IV sedation. This is usually indicated for situations where the patient is going to undergo extreme or surgical procedures where they are going to be completely sedated. Other surgical procedures include gingivectomy, which which is basically surgical removal of the diseased gingival tissue. This eliminates periodontal pocket and also recontours the tissues. Gingivoplasty is the reshaping of gingival tissues. This is done often immediately to remove any deformities. And this is a little example of what a gingivectomy procedure entails, where they grab a piece of the tissue that is either dead or it's no longer attached to anything and it's just hanging out here causing problems. They'll grab it and then they'll just incise it or just remove it either with a scalpel, interdental knives, or a laser. And this is an example of periodontal flap surgery, which is when the gingiva is separated and underlying tissue is exposed. So in this picture to the left, there looks like there was 2 incisions that were made, one here and then another one here. And the incisions are usually connected by a 3rd incision. And that whole flap of tissue is pulled back so that we can see the bone underneath, which is what we see on the picture to the right. This provides access for scaling and root planing, and also allows the dentist or the periodontist to reshape the bone. Other surgical procedures include osteosurgery, which is the reshaping of bone. This reshapes the bone to remove defects and restores normal contours. Mucogingival surgery is a reconstructive surgery on gingiva and mucosal tissues. One of the things that it can do is to cover exposed roots that are often sites for where calculus likes to stick to. It can also cause sensitivity for your patient. Gingival grafting is when tissue is removed from the palate, and it's grafted to areas where there has been severe gingival recession. If this is done, a periodontal dressing must be done to the donor site. Frenemectomy is the complete removal of a frenum. And both of these are done at times during reconstructive surgery. Guided tissue regeneration uses barrier membranes to maintain space between the gingival flap and root surface, and it also prevents interference of cells forming new structures. This technique promotes the delay of epithelial migration and gingival connective tissue from the surgical site in order for new cells to form and regenerate new tissues and structures, such as the cementum, the periodontal ligament, and alveolar bone. Periodontal dressings are not used for medicinal purposes, but are instead used to protect the tissue during the healing process. They serve to minimize infection, bleeding, protect tissues during mastication or chewing. They reduce pain. They provide support for the teeth and hold the flaps in place. There are a variety of materials that may be used, such as zinc oxide eugenol. There's also a non-eugenol type of material, light cured materials, and gelatin-based materials. Regardless of what material is used, the patient should be monitored for any allergic reactions. With periodontal maintenance procedures, the patient must commit to an oral hygiene regimen while healing and after healing to maintain the health and effectiveness of the periodontal surgery. There are many intraoral aids that are designed to aid the patient who has had periodontal surgery, such as cleaners, certain types of flosses, and water irrigators like water picks. The patient may experience mild to moderate discomfort after surgery and may take an analgesic tablet as needed. Prescription medication should be taken as prescribed, and the patient should limit activity for at least 24 hours following the surgery to prevent increased bleeding. Patients should not smoke or chew tobacco for 12 to 72 hours after, depending on the surgery. Okay, so that's it. That's all I have for chapter 31. Please let me know if you have any questions, concerns, or comments. Thanks for listening.